Good morning. Welcome to the Ceylon College of Physicians Young Physicians Forum. As usual, we have two speakers today who are senior registrars, and I would like to warmly welcome the audience and the two speakers for spending their time to come and present at this forum. So we have two speakers today, and we have half an hour for each speaker. The first speaker is Dr. Prianka Lohithalingam, who is a senior registrar in medicine at Teaching Hospital Batticoloa, who is going to speak on healthy aging, what it is and how to attain it. And our second speaker is Dr. A.M.P.M. Attanayake, who is a senior registrar in respiratory medicine at the National Hospital Kandy, who is going to speak on lungs after COVID-19. I would like to start with the first speaker, who is Dr. Lohithalingam, to speak on healthy aging, what it is and how to attain it. Over to you, Dr. Lohithalingam.
Thank you, sir, for that kind introduction. Good morning, everyone. Thank you. My special thanks to Ceylon College of Physicians for giving me this opportunity. And also, I would like to extend my thanks to the consultant who are at Teaching Hospital Batticoloa University Medical Unit for guiding me to prepare this presentation on healthy aging, what it is and how to attain it. The reason that I have selected this topic is populations are getting older. As per World Health Organization, you can see in this diagram that in 2015, the population who are at age 60 or above are only 12%. And they are expecting the population will rise up to 22% by 2050. And this crisis also includes Sri Lanka. We expect the population rise will be very high, and by 2041, 25% of the population will be at or above the age of 60 years. And you can see this population pyramid of Sri Lanka, and from 1981 to 2041, you can see the age distribution, the number of people during this age distribution. We are living longer, but the quality of life is not keeping pace with the rate of the increasing life expectancy. In the coming years, we will have more elderly citizens and fewer working age populations to take care of these elderly people. So we need to have our policy actions to overcome the problems that is going to come because of this aging population. More elderly people and few breadwinners to take care of them. So few notes on what is aging. It's, according to many biologists, it's the time-related deterioration of the physiological functions necessary for survival and fertility. Basically, people don't want to live long lives. They want to live long, healthy lives. Longevity is qualitative, not just quantitative. So just to classify the aging, objectively, aging is the universal process that begins at the birth and it's correspond to the chronological age. Subjectively, aging is markedly changes in the behavior and self-perception and reaction to biologic changes. Functionally, aging refers to the capabilities of the individual to function in the society. So the categorization is youngest old is the people who are between 65 to 75 years, and the middle old is 75 to 84, and the oldest old are the people above the age of 85 years. So the concept of aging, that means the chronological age is the actual number of age a person has been alive. Biological age is a general term used to encompasses the physiological process associated with aging, such as loss of muscle strength and endurance, loss of ability to resist diseases, wrinkle of the skin due to loss of collagen, and other deficiencies associated with the aging process. Psychological age is a subjective description of how one feels and acts and behaves. Social age changes in a person's role and relationship, both within their networks of relatives and friends, and in formal organizations such as at the workplace. We can exert some control on biological and psychological ages by various modifications of our lifestyle. We'll come to those things later. And when we see the physiology of aging, it starts from the molecular level up to the organ dysfunction. The molecular level changes are DNA damages, telomere shortening, epigenetic changes, and chromosomal mutations. And those will lead to cell malfunctions due to increased reactive oxidant species, protein desaturations, and also proteasomal dysfunction. This will lead to tissue dysfunction and ultimately organismal dysfunction due to impaired homeostasis, functional disorders, and increased susceptibility to disease and ultimately death. So these are the factors influencing in the aging. Genetic factors, it actually taking part of the 25% of the factors influencing in the age, and 75% is the environmental factors. The hereditary factors are the genes, mainly the longevity genes, ApoE, FOXO3A, 5q33.3. This last gene is the gene that was discovered lately, and it lower all-cause mortality in studies investigating the longevity locus and age-related phenotypes. And the other thing is epigenetic factors that influence the gene expression. And there are some personal characteristics influencing the age. Some are mobile and some are already fixed, non-modifiable things, age, sex, and ethnicity. And the environment. All the factors extrinsic in the extrinsic world are coming under this environment. Built environment, people and the relationships, health and social policies, the services, system that support them are coming under these environmental factors. So the domains of functional abilities moving around, building and maintaining relationship and meeting their own basic needs, learn, grow and make decisions, and their contributions to the family, society and to the country. So what are the physical and physiological changes of aging? As we all know already, these changes are seen in all the organ system: cardiovascular, endocrine, respiratory system, nervous system. Nervous system means it includes all three systems: motor, sensory and autonomic systems, musculoskeletal system, by reduction of the flexibility and also integumentary system, like we see graying of hair, wrinkles of the skin, and also immune system. Immune system with aging going into immunosenescence. That means unable to function properly. The immune cells are unable to function properly and they will be in a senescence state. So this will lead to immunosuppressive state in the elderly population. And ultimately, these changes results in chronic non-communicable diseases, malignancies, and functional cognitive impairment. The psychological changes can be seen in effect on confidence, their self-esteem, and effects of self-ageism, financial concern, and social disengagement. So because of these molecular level changes up to the organismal changes, and because of this increased disease, what are the impact of aging to the society and to the family or to the person himself? They have impact on the family structures, financial things, healthcare, and political impacts are there. So healthy aging is an investment, not a cost. What are the things we invest? Health system, long-term care system, lifelong learning, creating age-friendly environment, and social protections that will lead to the benefits of health, skills and knowledge, social connectivity, and also financial security and personal dignity. In return, we get the individual well-being, workforce participation, consumption, and entrepreneurship, and investment. And also social and cultural contributions will be the ultimate return from our investment for healthy aging. So what is healthy aging? WHO defines it as the process of developing and maintaining the functional ability determined by the intrinsic capacity of the individual, the environment they inhabited, and interaction between them. The goal is to maximize the functional ability of the elderly population. So, what will be the end result of successful aging? To minimize the risk of diseases and disability, continue to engage with life, maintain positive spirituality, and maintain physical and cognitive function. So, how to attain healthy aging? There are two approaches for that healthy aging. First one is always the prevention is better than a cure. So we have to delay getting old, and the old people also should be very healthy when they are very old. So these are the two approaches. So the behavior of a healthy lifestyle is the important thing to delay the aging. Eating a healthy diet, exercise, quit smoking, drinking alcohol in moderation, and adequate sleep and rest. And other important thing is coping up with the stress. So if we see the diet and nutrition, we have to make a healthy plate. Half of that plate should include fruits and vegetables. Fruits means not the juice, it should be the fruits, because they contain many fibers and antioxidants. They are having anti-aging properties actually. Vegetables, that should be non-starchy vegetables. And grains, most of our grains should be whole grains. Refined grains and processed grains should be limited in our diet, because they contain more, the whole grains contain more fiber, antioxidants, and many minerals. And also protein, that should be lean protein in beans, nuts, fish, and also chicken. So our food plate, as I have already mentioned, half of that should be fruits and vegetables, and the other half should be whole grains and lean protein. We can take small amount of dairy products and lean, low fat and non-fat dairy products. These are some foods containing anti-aging properties. So anti-aging properties are attained by containing many antioxidants that compact the free radicals formed during our various metabolic processes that are quickening the aging. Main things are nuts, especially almonds, walnuts, avocado, sweet potatoes, pomegranate, spinach, broccoli, berries, olives, dark chocolate, oily fish, and amla. These are some of the foods. And I want to give a small note on the amla, that is the Indian gooseberries. It's 1 or 2 amla a day is better than an apple a day. It reduces the amount of free radicals with high associated with anti-aging properties, and it is beneficial in reduction of weight gain, improve the digestive system, and many more health effects are there with amla. And of course, dark chocolates. It is also containing many nutrients, including antioxidants, and lowers this LDL and rises HDL with cardiovascular protectivity. And green tea. Green tea is mainly invented in the Far East countries, mainly Japan. It unsweetened green tea is having a lot of health beneficials compared with weight and also anti-aging properties. Foods to avoid are red meat, fried foods, and highly processed food should be avoided, and highly salted foods. There are two ways of getting the diet for the healthy eating pattern. One is the calorie restriction, other thing is the intermittent fasting. Calorie restriction is the reducing the calorie intake without causing malnutrition. When you cut the calorie by 25%, your life is prolonged by 30%. This is only observed in the animal models, especially in the rhesus monkeys in a study in America. Because it cuts the metabolism and thus reducing the free radicals. A trial called Calorie is tested the hypothesis of this theory. They have done this trial for 2 years among healthy young middle-aged population on obese people. 200 sample of people were taken for this study, and one side of the population were given calorie restricted food and the other one was taking normal diet. And at the end of 2 years, they have evaluated with various measures and found that this calorie restriction has multiple cardiometabolic risk factor reduction in young non-obese adults, and they offer promising results for the long-term benefits also. And intermittent fasting can be done in various ways, skipping one meal a day or skipping for 5 days a week you eat normally, and then next 2 days you can eat food with some calorie restrictions. And sometimes you can be fast for 24 hours. And sometimes in a day you can eat for 8 to 10 hours and fast for 14 to 16 hours. Other important thing is the exercise. Exercise improve this exercise has various health benefits. It involves reducing blood pressure, improve insulin sensitivity, improve body flexibility, immune functions and balance, and every body weight maintenance. Everything is due to physical activities, and there are 4 major ways: aerobic activities, resistance training, flexibility training, and balance training for elderly. And a small note on yoga, even though it's known in the ancient time, it's gaining its wide popularity in the recent past. It's exercise flexibility plus meditation. And it has many psychological and physical benefits. And like that, meditation is also another important factor to combat the stress, and with various health benefits in our body to come with many stress relief, boosts immunity, weight management, anti-aging properties, and a lot more. Adequate sleep. They recommend at least 6 hours of continuous sleep is important for reorganizing our mental status. And World Health Organization has declared the year starting from 2021 to 2030 as a decade of healthy aging. And they have many goals, and they have many aims to maintain. The older people should meet their basic needs, continue to learn their decisions, and they have to be mobile and maintain many relationships. And they have many areas of action to promote age-friendly environment, combating ageism, that is removing the negative attitudes about older people such as stereotyping, prejudice, and discrimination, and integrated care and long-term care. And in our country, we also have many national policies for healthy aging and in the health of the elders. National Council for Elders and National Council on Secretariat for Elders. And we have our own national policies based on the recommendations of Second World Assembly on Aging held in Madrid. And we have our national councils including government sectors and non-governmental organizations under the observation of WHO and United Nations Fund for Population Activities. We have our own set of objectives like protect and promote the rights of elders, to identify the problems they are facing and to improve their various skills, and engaging them in various programs. Main strategy is establishment of elders committee and getting them involved in the financial aspect of the family as well as in the community. And we have various action plans to maintain that. And finally, in conclusion, live long and prosper. This is the end result to which we all aspire, and it can be achieved we can start at any stage of our life in this goal by modifying our lifestyle, healthy lifestyle. Eat variety of fruits and vegetables, as I've already mentioned, being engaged in the activities, physical activities, and like that. So thank you for listening. And September is going to be the healthy aging month. Thank you.
Now it's a question and answer session. We didn't receive any of the questions online. Dr. Pulis, over to you.
Yes, Dr. Lohithalingam, thank you very much for delivering that very listenable and timely lecture. And thank you very much for keeping time. A few questions. And in your lecture, I saw that to delay aging, you advocated drinking alcohol in moderation. Now, to people like Shamita and me who don't drink, do you advocate starting to drink?
Actually, red wine is the only alcohol that is kind of recommended for a healthy aging. But in the recent researches, it is told that the benefits of them is more than the disadvantages of alcohol, because it's involved. It can lead to many kind of malignancies. Only the red wine is recommended. All the other alcoholic beverages are not recommended. So you can continue having no alcohol.
Thank you very much. But if you're quoting this California red wine study, let me remind you that the chief investigator of that study was discredited and taken off the university because he has doctored the data because he was funded by French wine producers. So that California red wine study is no longer a quotable study. Second thing is that you said taking green tea is helpful in healthy aging. Do you have any evidence to that fact?
There is no scientifically proven evidence, but in Japan, the Okinawa, that is the place where the population are living more. Around 2/3 of the population are above 97 years, and they are actively involving in all kind of activities. They are physically independent and also not dependent on the others for their financial as well as all the supports. And in them, they are regularly taking unsweetened green teas with other lean proteins, seafoods, and quitting. They are taking only very limited amount of processed food. So one of their main ingredient in their diet is green tea. I couldn't find any scientifically proven data for green tea, but it's a practice which is there in the Far East countries.
Probably this is what we call the anecdotal evidence. Yes. Lastly, you didn't touch sexuality in elderly.
Yes, sir.
Thank you.
Okay, thank you, sir.
Right, Dr. Priyanka.
Yes.
I'm Professor Kamani Manigasuriya. Can you hear me?
Yes, madam, I can hear you.
All right. I must congratulate you for selecting this topic. Right. So I have a couple of questions. Actually, when you think it is the best time to educate people regarding healthy aging? You said, any time of your life, maybe when you are, too young, you might not be interested. Right. What do you think?
At least by the age of 40, they are recommending to start the things that prevent aging, and asked to take the things with anti-aging properties such as diet, exercise, yoga, meditation, and other and quitting the vices. But it's better to start even before that for a healthy lifestyle.
Okay. Then about intermittent fasting, is there any research evidence available, and is it quite, safe for, very old people?
I was searching for evidences on that, but I couldn't find many evidence for that. Only I saw some evidence for that calorie restriction.
Okay, right.
There
So
are
that-
only animal studies are there on that. Human studies are very limited, even for calorie restriction.
Okay, thank you.
Can I ask a question? I'm Senaka Rajapaksa.
Okay, sir.
Can I ask a question? If
Yes,
Kamani, you
sir.
have finished?
Yes, yes. Yeah.
Well, again, I think it's related to the questions that Upul and Kamani asked. So you mentioned a lot of interventions in terms of dietary changes, lifestyle modification, in terms of intermittent fasting, yoga, all those things. Let's just talk about the dietary modifications, and you recommended certain types of foods as being beneficial. Is there any scientific evidence for the use of these this particular diet that you mentioned? And similarly, is there any scientific evidence for intermittent fasting? I think Kamani asked that question, and that's been answered. And is there any scientific evidence for yoga, meditation, any of those things? Because if there is no scientific evidence, why would you advocate them? For example, you're going to tell an elderly person not to drink alcohol when it might not really have any impact at that age. Similarly, you might be telling a person not to eat some puddings and chocolates and pastries and things, when actually that might not that might not extend their lives or change their likelihood of developing a cardiovascular event. So if we are to make statements about diet and recommendations about diet, shouldn't it be based on some scientific evidence?
Yes, sir.
So have you got any evidence for any of these dietary interventions?
I couldn't find much evidence for them, but only based on the molecular changes of aging and the health benefits of this diet. Most of the dietitians and the people who are working on aging and healthy aging people recommend these kind of diets because of the free radicals are the main culprits of telomere shortening, and many molecular damage occur during the process of aging. And these foods that I have mentioned are containing antioxidant properties. So they expect and they have proven by their experience that these are delaying the aging. But I couldn't find scientific
proof like that. Is there scientific proof that they will delay aging?
For the foods I have mentioned, I couldn't find, sir. But for the practice of calorie restriction, I have found some
right
evidence. And for the yoga, there is a meta-analysis published in 2019 issue of International Journal of Behavioral and Nutritional and Physical Activity that provides strong evidence of benefits of yoga.
Okay, thank you.
Thank you.
We have a couple of minutes for questions if there are any. Shavita, anything online?
No, sir, there's nothing on the online.
So in the absence of further questions, thank you very much, Dr. Lohithalingam, for that extremely interesting presentation, and wish you all the best. Thank you.
Thank you, sir.
We can move on to the second talk, which is by Dr. A.M.P.M. Attanayake, Senior Registrar in Respiratory Medicine, who is going to speak on a very timely topic, that's the lungs after COVID-19. Over to you, Dr. Attanayake.
Okay, thank you very much, sir. First of all, I would like to thank Ceylon College of Physicians for this opportunity. Today my topic is lungs after COVID-19, and I would like to start the presentation with two cases. The first one, Mr. A, a 65-year-old patient with diabetes and hypertension, presented with cough and shortness of breathing for 9 days duration. And on admission, his respiratory rate was 30 and had a saturation of 83% on room air. And on investigations, his COVID-19 RAT and PCR was positive, and CRP was high with a normal procalcitonin. and chest X-ray showed bilateral lower and middle lobe opacities. Initially, he was started on oxygen 60% via Venturi device and started on IV antibiotics, IV dexamethasone, and prophylactic dose of enoxaparin. And on the 5th day of hospital stay, the patient clinically deteriorated with increasing oxygen requirement, and then he was transferred to the hyperdependence unit and started on high flow nasal oxygen. And during the ICU stay, his inflammatory markers, including CRP and serum ferritin, gradually came down, but he had high oxygen requirement. And he was slowly weaned off from oxygen, and he was in the ICU for about 3 weeks and discharged with a 40% oxygen. He came back to the ward. And we have done a HRCT on the 32nd day of the illness. It showed a predominant organizing pneumonia pattern with few areas of ground glass and some evidence of fibrosis like traction, early evidence. And with that, he was started on IV methylprednisolone 1 gram daily and given for 3 days, followed by oral prednisolone 1 milligram per kg per day. But despite this treatment, he remained oxygen dependent. On the 48th day of the illness, his room air saturation was 87%, which desaturated to about 78% with minimal exertion. And he maintained a normal saturation with 4 liters of oxygen via face mask. And after 2 months hospital stay, he was discharged home with home oxygen via an oxygen concentrator. The second case, a 70-year-old patient with hypertension and dyslipidemia presented with 2-week history of dry cough and shortness of breathing. There's no history of loss of appetite, loss of weight, no joint pain, skin rashes, or other features of autoimmune connective tissue disorders or vasculitis. As a non-smoker, and there was no history of organic or inorganic dust exposure. His wife became positive for COVID-19 about 1 month back. At that time, he also had some low-grade fever with arthralgia myalgia, but at that time, his COVID PCR was negative. On admission, saturation was about 88%. His basic investigations, including full blood count, liver, and renal profiles, are normal. COVID-19 RAT and PCR was negative. Inflammatory markers were normal. Autoantibodies, including ANA, rheumatoid factor, C, and Prianka, was negative. But his COVID-19 IgG antibody became positive. We have done a HRCT chest. It showed reticular shadows with a few areas of ground glass opacities, predominantly involving basal subpleural areas of the lung. And there were few areas of consolidation. It showed a NSIP plus organized pneumonia pattern. Again, he was given 3 passes of IV methylprednisolone followed by oral prednisolone. He has improved following IV methylprednisolone pulse therapy and weaned off from oxygen. After about 10 days hospital stay, he discharged home. And he came back for clinic follow-up. On 3rd month, he was clinically static, but still had a MMRC grade 2 dyspnea. So this HRCT was done after 3 months. It showed resolution of this like consolidations and ground glass opacities mostly, but there was progression of fibrosis evidenced by bilateral traction bronchiectasis, mainly in the bases. So we have planned to tail off his prednisolone, and we have started him on pirfenidone. So lungs after COVID-19, what do we know about it so far? First, when we can diagnose post-COVID lung disease. So this is an article published on Nature Medicine about a few months back. There they categorize acute COVID-19 as the signs and symptoms of COVID-19 from the onset of symptoms until 4 weeks. And the signs and symptoms of complications occurs after that are defined as post-acute COVID-19. That also subdivided into 2 groups, subacute or ongoing COVID from 4 to 12 weeks, and chronic or post-COVID-19, that is after 3 months. This is again from the same journal article. The first 4 weeks after the symptom onset defined as acute COVID-19, and after that, that is post-acute COVID-19. From 4 to 12 weeks, subacute or ongoing COVID-19, and after 12 weeks, that is after 3 months, it is chronic post-COVID-19, during which we can have almost all the system involvement, including the lungs. Again, according to the NICE guideline on long COVID published last December, they also have a similar classification: acute COVID-19 up to 4 weeks, ongoing symptomatic COVID-19 from 4 to 12 weeks, and post-COVID-19 syndrome, the signs and symptoms or complications develop or continue for more than 12 weeks, which are not explained by an alternative diagnosis. Then what are the pulmonary manifestations during the subacute or ongoing phase, that is between the 4 weeks and 12 weeks of the illness? So first, what are the prevalence of respiratory symptoms? This is an article published on the BMJ, which had about 47,000 participants. It's a retrospective cohort study in NHS hospital, almost all the NHS hospitals in the England. Mean follow-up was 140 days, slightly beyond our post-acute phase. But here you can see in the last row, the new onset respiratory events were about 21% in the patients with COVID-19 compared to 0.8% in the control group. The control group is aged and sex match the normal population who didn't have COVID-19. So there's a significant increase in the prevalence of new onset respiratory symptoms. And then another study published on the Annals of Thoracic American Thoracic Society, persistent post-COVID interstitial lung disease, and they have assessed the effect of corticosteroid treatment also in this study. Here they have assessed about 800 patients with COVID pneumonia and followed up 6 weeks after discharge. 39% of the patients had ongoing respiratory symptoms. So then what are the lung function abnormalities during this post-acute, the subacute phase? In this article published on Pulmonology Journal, they have it's a meta-analysis of about 380 patients. All the lung functions are done exactly during this subacute phase, 30 days to 3 months. They have found a restrictive type of a lung abnormality in about 15% of patients, but more interestingly, the diffusion capacity was reduced in a significant number, the 39% of the patients. Then what are the radiological abnormalities? This is the same study about that corticosteroid treatment. So they have done chest X-rays in symptomatic patients, and they have went on and did HRCTs in the patients who had abnormal chest X-rays. So 59 patients out of 387, that is about 7%, had persistent lung parenchymal abnormalities. Majority, that means about 35% of the 35 patients had organizing pneumonia, and the rest had limited disease, mainly ground glass involving less than 15% of the lungs. So what is the pharmacological management? And this is the only study I could find, the same study. They are, for the 35 patients with organizing pneumonia with restrictive lung physiology, they have started corticosteroids, oral prednisolone 0.5 milligram per kg, and it was weaned off rapidly over 3 weeks duration. And at the end of this prednisolone course, short prednisolone course, all the patients reported improving their symptoms. And then there was a statistically significant improvement in MMRC dyspnea scale, forced vital capacity, and TLCO. And they have done HRCTs after the treatment. The repeat imaging demonstrated that the consolidations have resolved into ground glass opacities. And more importantly, there was no ongoing inflammation, or there was no establishment of fibrosis. And then how many patients require long-term home oxygen after discharge? And this study published on Annals of Internal Medicine in April 2021. They have followed up patients with COVID-19 pneumonia. Out of 488 patients, 6.5 patients were on home oxygen therapy 60 days after discharge. And another 6.6, that is 34 patients, were newly started on CPAP or other breathing respiratory support during sleep. Then we'll move on to the chronic post-COVID phase, that is after 3 months. So again, what are the prevalence of respiratory symptoms and lung function abnormalities? There was a fairly large article published in the Lancet journal, which included about 1,700 patients. It was done in Wuhan, China. And the median time of follow-up was about 6 months after the symptom onset. Here they have analyzed the data according to 3 categories. First, the mild disease, the patients who had COVID-19 but who didn't require oxygen. The second group who required oxygen but with like simple devices like maybe face masks and nasal cannula. Third group is the group who had severe disease who required high flow nasal cannula oxygen, NIV or invasive mechanical ventilation. Out of those, about 24% of patients had MMRC grade 1, more than MMRC 1 dyspnea at 6 months compared to 36% of the patients who had severe disease. But almost all the groups had like satisfactory lung function, 6-minute walking distance. And the lung function tests, there was no significant obstructive abnormality, but restrictive pattern reduction in total lung capacity was seen in 11% of patients with mild disease compared to 35% of patients with severe disease. And more than that, again, the DLCO impairment was seen in about 22% of the patients with mild disease compared to more than 56% of the patients with severe disease. This is after 6 months. Then what are the radiological abnormalities? This is from the same study. Nearly 50% of the patients had some sort of a abnormality in the HRCT chest in all 3 groups. Predominant pattern was ground glass opacity according to this study. But importantly, the linear shadows, which suggest fibrosis, was seen in only about 11% and 15% of the patients with mild and moderate initial illness, compared to 24% of the patients with severe illness. There's another article published on the Radiology Journal. They have again assessed 114 patients with severe COVID pneumonia. This whole group has severe COVID pneumonia. And again, repeat HRCT was done after 6 months. It showed 35% of the patients had fibrotic-like changes, and only 27% had ground glass opacities, and the rest had normal CT. And increased age, longer hospital stay, ARDS, and NIV use as the independent predictors of developing fibrosis on the HRCT. And then what is the pharmacological management during this chronic phase? Unfortunately, I couldn't find any evidence up to now, but there are a lot of studies going on, mainly assessing the efficacy of pirfenidone and nintedanib, like antifibrotics for the chronic COVID-19 induced lung fibrosis. Results will be available in the next year. And then there was few studies on long-term effects, which occurs after 1 year. This is a follow-up study of the one that I have described previously, again published on the Radiology Journal. They have done repeat HRCTs in like nearly all of the patients who had abnormalities at 6 months. Interestingly, 100% of the patients who had fibrotic changes at 6 months had persistence of fibrotic changes after 1 year. About 77% of them had stable lung fibrosis, but and rest the 23% had slightly improvement of fibrosis. And patients who had non-fibrotic changes like consolidations and ground glass opacities showed 63% of them showed complete resolution, and other had improvement in their lung changes. So these suggest that these data suggest more severe initial illness leads to more fibrotic changes in the lungs, and if you have fibrotic changes, you tend to have poorer outcome, at least radiologically, compared to initial milder disease can have long-term effects in the form of non-fibrotic lung disease, but they tend to have more good prognosis compared to the other group. In another article published on Lancet Respiratory Medicine, they assess the respiratory outcomes in 3, 6, 12, and 9 and 12 months. Again, after 12 months, this study group was a moderate kind of a patients with COVID pneumonia who didn't require mechanical ventilation. Only 5% of them had symptoms, and 11% of them had impaired FPC, similar results, with 33% of them had impaired DLCO. And this is the moderate group, as I mentioned. About 24% of the patient had abnormal HRCT, but none of them had established fibrosis. So we all know that hypercoagulability, acute COVID-19 is a hypercoagulable state, and with lot of venous thromboembolic events. But does it last beyond acute phase? This is a large study with about more than 250,000 patients. It's a retrospective cohort study. They have assessed the incidence of DVT and pulmonary embolism after 200 days. This was published in BMJ. And they have compared it with the non-COVID patients and in the same year, this is 2020, and the data of the previous year. Compared to those two groups, the COVID-19 patients had increased incidence of thromboembolic events, that is DVT and pulmonary embolism, even after 200 days. So what are the evidence to be expected in the future? There are a lot of ongoing studies on post-COVID-19 interstitial lung disease. UK ILD long COVID study to assess epidemiology, clinical characteristics, and prognosis of post-COVID ILD. And another study to assess the efficacy of methylprednisolone. This calls the study to assess the efficacy of medium dose versus low dose prednisolone in COVID-19 ILD. Perfenidone, fibro-COVID study to assess efficacy of perfenidone in post-COVID-19 induced lung fibrosis. Another study comparing perfenidone versus nintedanib. These results will be available in the next year. So in summary, a significant proportion of patients have respiratory symptoms and lung function abnormalities with radiological changes during subacute and chronic phase of COVID. Long-term lung involvement is more severe in patients with severe COVID pneumonia, but significant disease can be seen in patients with mild COVID disease, but they tend to have good prognosis compared to the severe group. And oral prednisolone shown to improve symptoms, lung functions, and radiological abnormalities in organizing pneumonia during subacute phase. And we need further studies to understand this post-COVID lung condition and its management. So thank you very much. And I would like to thank my trainers, Dr. Anoma Siribadana and Dr. Amila Ratnapala, for guiding and helping me with this presentation. Thank you.
Yes, thank you. And it's a question and answer session. We didn't receive any of the online questions. It's over to Dilshan.
Thank you for that presentation. I would like to ask one question now. Talking about the effects of COVID pneumonia, are there any evidence or have anyone looked at treatment-wise whether we can halt the disease progression from the acute the onset of itself? So like we are using tocilizumab and steroids in different doses. So are there any evidence to suggest?
No, sir, I couldn't find, but there are ongoing studies to assess the efficacy of colchicine and sirolimus to prevent the development of this post-COVID lung fibrosis. But up to now, I couldn't find any evidence.
Are there any even retrospective analysis?
I couldn't find. No.
Okay.
Hello, I'm Professor Kamani Vanigasuriya. I'm joining on Zoom.
Yes,
now about this chronic fibrosis that happens at the chronic stage, other than the disease severity, are there any other predictors, any other factors people have recognized that could predict the long-term fibrosis?
Yes, madam. The older age and the severity, that is older age, and there was something. Longer hospital stay and was associated with poorer prognosis. And other than that, in another study, I didn't include it here, obesity was also associated with the development of lung fibrosis.
Okay, thank you. So we don't know what type of percentage, go on to develop lung fibrosis. Any? No, maybe difficult.
Yes, madam. Very limited data is available at 6 months. About 5% of patients with the available data at 6 months. About 5% of the patients with severe initial disease are going to develop lung fibrosis. It seems.
Right. Thank you.
Dr. Attanayake, now there are these people who are just COVID positive, and they have not got any symptoms. They are asymptomatic, and they have no evidence of lung involvement. When you do the oxygen saturation, their oxygen saturation is 100%, and after exercise also their oxygen saturation doesn't drop. You don't do a chest X-ray, you don't do HRCT, you don't give them anything. You just keep them and reassure them that they will be all right. And so from your talk, what I gather is that asymptomatic people also in the long run can develop lung problem. Is it true?
See, yes, sir, yeah. They also can go into develop some sort of a lung symptoms. According to this nice guideline published last December, they advise to follow up, at least have a telephone follow-up conversation at 6 weeks after discharge to detect whether if the patients are having any symptoms. If they are symptomatic, then they advise to go on with other further investigations like chest X-ray and beyond that.
Yeah, in
Any
the
further
absence
questions?
of,
Shamita, anything from the audience?
no, sir, we didn't get any of this.
So then I suppose we can wind up this session. So I'd like to thank both of the speakers for their excellent presentations and for enlightening us on aspects of old age and also aspects of fibrosis in COVID. I'm joining on Zoom, so Shamita, I think you will be doing the honors with the certificates.
Yes, I'll do. Dr. Prianka Lohithalingam. Dr. A.M.P.M. Attanayake.
So thank you very much. And we will close that session at the moment. I'd like to thank the sponsors, Cipla Pharmaceuticals, the IT staff, the audiovisual staff who as always gives us full support at these sessions, these webinars in these times of difficulty. The staff for the ClinMark and Dr. Nuwan Ranawaka and Dr. Well, they are not directly involved at the moment, but sorry, that's for the next session. We have a little break now. Shamita, we will have to wait for a few minutes, isn't it?
Yes, sir. We'll wait for a few minutes and we'll restart again.
We'll pause for a few minutes and come back in a few minutes' time.